I'm Steve Kossor. I'm a psychologist. I live in Pennsylvania. I have been doing a lot of the things that Dr. Embry has been documenting for close to 30 years. Unbeknownst to me, I have kindred spirits, and lots of you people are them. So I feel honored and privileged to have been recognized as a contributor to your process. The good behavior game, the PAXIS Institute, all of the work you're doing is startlingly effective. I know because I've been doing a lot of it with my staff in Pennsylvania for the last 30 years. Bottom line, I want you to know that there are two brochures over on the side there. One's purple, one's white. If you'll pick these up, you'll have a good understanding of what I've been doing in Pennsylvania since about 1981. My staff, to summarize it shortly, goes into the home and school of the child, hangs out with the child where the problems are occurring, does what they do, including what you're talking about, evidence-based kernels. Delivers the treatment interventions in these kids' lives, and over time get farther and farther away until they're not necessary anymore. In the meantime, they are projecting a little bit of a force field around the child that repels some of the negative and abusive influences that the poor kid's exposed to. Because he's an impaired child, he's got disabilities, he's got the deck stacked against him, and I use the word he to be referring to both boys and girls. The sad part is we are producing impaired children at an unprecedented rate. Dr. Embry has documented it. Back in 1967, when early and periodic screening, diagnosis, and treatment, EPSDT, was created by an act of Congress, the military was alarmed because approximately 50% of the kids showing up at draft boards during the height of the Vietnam War were unfit for military service. Almost 50%. Well, Dr. Embry showed you this morning that now it's up to 75. Good Lord, it's gotten worse in the last 50 years. And this is while a viable program for funding the treatment of mental illnesses, vision, dental, and a host of other problems has been available in the United States. This is the EPSDT program. It's been part of Medicaid since 1967, and it's been a mandate in all 50 states for any child enrolled in Medicaid since 1989. This is the best kept secret on earth. In fact, when I do these talks all over the country, I refer to EPSDT as the greatest treatment funding secret ever concealed. Schools are tapping Medicaid to the tune, I'm not kidding, annually in every state over $100 million. And they have been doing this for at least a decade. So we're talking $50 billion of Medicaid funds that have been consumed, let's use the most polite word I can think of, by schools of Medicaid funds to do what? And the only answer is to supplement the school's special education budget, whatever that means. So you can think of Medicaid as having a configuration like a keg. It's got two taps. It's got the school tap that kind of runs out the back and is running full tilt. No managed care oversight, no controls really. It just goes out from Medicaid into the school special ed budget, funds trips, trainings, whatever the administration of the school can justify as a special education expense. But the other tap at the top of the Medicaid keg is what I want to talk to you about more so than the school tap. If you go to, I'll give you a couple of resources, go to the National Alliance for Medicaid in Education, NAME. It's an online presence. Those people know how to use Medicaid to fund a special education budget in any school in the nation. They're a national organization. I presented at their conference once. I'm a licensed psychologist and a certified school psychologist, and I firmly believe that schools should not be forced into the role or even accept the role of being everything that every kid needs no matter what. It's a mistake. You have the concept of a jack of all trades. What are they the master of? None. Okay. So schools have no business putzing around, and that's literally what they do for most kids. They putz around with special education and behavioral treatment. They are so antiquated in their understanding of special education and mental health support that how many of you are aware of schools that implement the no child gets ahead rule? I'm sorry. Okay? That's a colossal affront to humanity in and of itself. But how many of you know about schools that implement the No Prisoners Act? What's the right word for it? It's the concept that there is zero tolerance for aggression. This is insane. You punish the victim as well as the perpetrator. Everybody suffers, and the only ones who benefit theoretically are the union members. So the bottom line is I'm not a friend of schools in the sense that if they would do what they can do to implement modern standards for mental health treatment, like what PAXIS is recommending, we know from all of the studies that have been done that this stuff works. So the hard part is how on earth do you get it across to schools that it works? And my reason for being here, I was at the Center for School Mental Health Services conference about a month ago, and I met Dennis. He did one of the keynotes there, Dennis Embry. And I went up to him afterward and I said, "You're doing what I'm doing. This is fantastic. I can help. I know about EPSDT funding." And he said, "Wow, I've got a conference. Can you come to it?" Sure. So I go all over the country and I give these talks to try to help good people understand how to get good money to do good work, right? It's just that simple. EPSDT funding is a civil right. Cross my heart, I know that's true because I filed a civil rights complaint in Pennsylvania in 2012 that is currently under investigation officially by the Office for Civil Rights because I found that children were not being allowed access to EPSDT funding in accordance with federal and state laws. And I'll explain to you what those laws are shortly. So I filed this complaint, and the Office for Civil Rights is actively investigating it, so you can tell what kind of a list I'm on in Pennsylvania. But nevertheless, I'm continuing to do this, and I continue to talk about this because it is the right way to fund mental health treatment for children, and that's anyone under the age of 21 who has a disability. That's the criteria for admission into EPSDT funding, as long as you're enrolled in Medicaid. And the most important thing to take away from the meeting today, and this is going to be a short 1-hour condensed version, is that there is a list of 36 states in which enrollment in Medicaid is permitted regardless of family income. So if you're in one of these 3/4 of the United States states, it doesn't matter if your family has 3 cars or no car. If you're a disabled child under the age of 21, you are entitled to funding for treatment, wait for it, that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished. That is a direct quote out of federal law, 42 Code of Federal Regulations, Chapter 4, Section 438.210. B. Okay? I've been at this for a long time. And literally, I'm going to do this speech extemporaneously rather than try to follow slides and nonsense like that. If you will write your name and legibly print your email address on a piece of paper over by my literature, I will send you a copy, because we're recording this. I'll send you a copy of my recording synchronized with the slides. Oh my God, right? And you can then invite me to your own school. We do WebEx conferences. I do this stuff all over the place. And I will get as much information in your hands in the next 50 minutes as possible. We're going to scratch the surface. Okay, so you now know that 42 Code of Federal Regulations, blah, 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 entitles a child enrolled in Medicaid to treatment that is sufficient to help them, period. When that access to that funding is impeded, it is a violation of that child's civil rights, period. And that's true in all 50 states. So what I'm going to show you now is how EPSDT funding for home and school-based mental health treatment is accessible under the Medicaid Act. First of all, let me just give you something so you understand that I have some credibility. This is a letter that my congressman received from Cindy Mann, who's one of the directors of the Centers for Medicare and Medicaid Services. Now, that's a federal agency. Those guys don't endorse anything for anybody ever. But this is a quote of what Ms. Mann said. My staff has spoken with Mr. Kossor, and we learned that he has indeed developed an effective approach to serving children and adolescents with developmental disabilities and has made the approach available to Medicaid-enrolled children through EPSDT. If that's not an endorsement, there are more laudatory comments in there. So they know what I'm saying is true because I've sent my stuff to them. And I've said, is this a service that is funded under EPSDT? And I got a resounding absolutely. That means this can be done in all 50 states for any child enrolled in Medicaid who has a disability. And she focused on developmental disabilities. Kids with ADHD, they don't have to be developmentally delayed in order to benefit from what I'm going to describe. And what I'm going to describe is actually called Behavioral Health Rehabilitation Services, or BHRS. BHRS is part of the rehabilitation option that was implemented in all 50 states no later than 1989. It's part of Medicaid, part of the Social Security Act. It's a civil right. Kids are entitled to BHRS if it is prescribed by a licensed practitioner of the healing arts under scope of state law. And in Pennsylvania, psychologists fit that bill. Physicians fit that bill in all 50 states and can certainly prescribe behavioral interventions. Every pediatrician has all prescribed feeding programs, toileting programs. They do that as a matter of course. Those are behavioral interventions. So every physician, every pediatrician can prescribe what I'm going to describe to you. Preferably, you want to have it prescribed by somebody who has some credentials in mental health treatment. So I'm going to recommend seek out a licensed psychologist to go the next step. The next step relates to what EPSDT is, and you'll see in the highlight, state Medicaid programs must make EPSDT services promptly available for any child under 21 who is eligible for Medicaid, whether or not that individual is receiving services under a waiver or any other state plan. Let me help you understand the difference between a waiver and EPSDT. This is a box of breath mints. There's 50 in them, 50 in this box, and they're all free. And the states all say to parents of kids with disabilities, here, this is yours, it's free. And they expect the parents to say, my God, thank you. But wait, there's a 3-year waiting list, and this amounts to $10 a year for 10 years. Stop. That's what a waiver is. In contrast to a waiver, there's a wallet full of credit cards with literally an unlimited balance on them with the child's name on it. That's what EPSDT is. So let me give you the backup that proves that I'm not just psychotic up here. It's federal law. It's the Social Security Act. It is not negotiable. It's law in all 50 states. And under EPSDT, for a child under 21 who is disabled, they're entitled to funding that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished in order to address treatment and prevention services, as well as physical, speech, and related therapies, hearing, eye exams and eyeglasses, durable medical equipment, home, residential, and inpatient care, dental care, and other services, including mental health care. This is also now incorporated into the Affordable Care Act. It's also part of every other legislation aimed at supporting the needs of disabled people, including IDEA and the Rehabilitation Act. Remember, I'm implementing behavioral health rehabilitation services. So this is covered 6 ways to Sunday, and this is how you can force the state authorities to do something other than send money to the local grammar school. Again, I said Chapter 4, Part 440.130 describes the actual term in law that covers EPSDT. It includes diagnostic services, preventive services, and rehabilitative services. You see these highlighted words, recommended by? This allows a person who is not licensed themselves to participate in diagnostic services, because all that has to happen is the diagnostic services have to be recommended by a licensed practitioner. So in my own organization in Pennsylvania, I have unlicensed people working under my scope of practice who participate in diagnostic exams. I share the workload with them because I'm really taking responsibility for these 20 and 25-page evaluation reports that we're producing. They spend a lot of time collecting behavioral data. They can bill for that activity because it's part of what is called behavior specialist consultation services, which are billable under Medicaid. So they're doing their job under Medicaid, collecting data, analyzing and monitoring and assessing progress, and in the process they're feeding me a growing body of data. And when I'm ready to see the child face to face, I take that body of data with me. I interact with the child, the parent, the teacher. I go to the home and or the school, and I finish a life domain biopsychosocial evaluation report that explicitly describes the deficits the child has, the strengths they have, and the needs they have for behavioral support. And then I prescribe exactly what the child needs. With all of that data behind me, what is the chance that an insurance company sweeps it off the table and says, "Now we don't do that here"? Believe it or not, there are some insurance companies that do that, but there is an appeal process that's built into the system where I just appeal and appeal and appeal and appeal, and eventually I meet somebody who understands the law, perhaps the Secretary of the Department of Public Welfare, or if even that person is behaving badly, what do? I package it and send it to the Department of Justice as further evidence of the obstruction of the civil right to treatment that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it is furnished. Who determines the purpose for which the treatment is furnished? Me, who saw the child, interviewed the teacher, or a licensed professional sitting in an insurance company funded chair who reads my report and has the temerity to pass judgment on it and say, "Nah, he doesn't need 30 hours a week, he needs 5 or none." When that kind of an outrage happens, we appeal it and we wait for somebody to do the right thing. And more often than not, yeah, they do the right thing. Because we've got a 25-page report with data collected every single week to justify the continuing need for treatment. And we do this all funded by EPSDT in the child's home and school. And we do this, 90% of the kids we work with are finished with our interventions within 3 years, not 3 months like they would have it. But we work with kids until the treatment program is finished, or until the parents say, "You know, this is as good as we think it'll get." And we try to appeal to them that, you know, it could get better, And every once in a while we draw a short straw. There's no perfection in any aspect of life. This is an organic system, and sometimes we have lousy providers. They don't last. They get trained and supervised weekly. So they don't persist in a kid's life month after month, God forbid year after year. They get trained and remediated or replaced, so that we have a track record that's been investigated by the University of North Carolina at Chapel Hill, Thomas Jefferson University in Philadelphia, Villanova University in Pennsylvania, and Immaculata University. 4 different independent research bodies have looked at the data and said literally, wow, 75 to 85% of the kids you work with are showing improvement in 4 months or less. And over time, as you work with kids for a year, their improvements increase. I have no doubt whatsoever that when I start infusing my staff with the good behavior game and all of the other kernels that I've only recently become aware of, the rate of improvement is going to skyrocket. And not only that, it will be used as a means of introducing these brilliant concepts into schools funded entirely by Medicaid. That's why I'm here. All right, so now we look at rehabilitative services. Again, these are services recommended by a licensed practitioner. So if I prescribe a service where a person with a master's degree goes into the home and school of the child, meets with the parent, meets with the teachers to teach them better strategies for behavior management, do you hear evidence-based kernels here? Okay? That's what we're talking about. If we have master's level mental health professionals who are astute in their assessment skills and competent in their use of the evidence-based kernels, this is a perfect storm funded by Medicaid. So that's the strategy here. I think what Dr. Embry did is he took a lot of concepts that float in the ether, like contingent contracting and all this stuff that Skinner wrote about, and he brought it down to earth. He made it real, right? So that's part of what he did, but he did more than that. His concept about evolutionary psychology and how he's joining with that is just nothing short of brilliant. It's the most exciting psychology stuff I've seen in 30 years. So I'm terrifically pleased to be a part of what you're doing, and I hope I can contribute to your ability to get it out more abroad in the land. So that's how we do it. We use rehabilitation services. One quick note. You see this here? It says provided by, preventive services provided by. In the original EPSDT legislation back in '67, they said, oh no, prevention has to be done by licensed practitioners only. Well, now we know better, and in fact, the Affordable Care Act amended that, and now prevention services can be implemented by people who are not licensed under the scope of practice of licensed professionals. There are 3 key concepts I want to make sure you have. The first is that each service must be sufficient in amount, duration, and scope to reasonably achieve the purpose for which it was furnished. I determine that, or any other licensed practitioner who prescribes it, and therefore the insurance company can quibble, stamp up and down, bang their fist on the table. They're like a pit bull, a monster pit bull with an 18-inch chain around its neck, and all it can really do is make a lot of noise. Once you get that, and you understand that the state Medicaid authority in every state does not like this message, because it means that literally every single child with a disability in 36 states is entitled to treatment funding through EPSDT until they turn 21 as a civil right. Oh my God, this will break the bank. Everybody is going to lose everything. Life as we know it will end. It's nonsense. There are kids who desperately need behavioral support. Not everybody is smart enough to prescribe this, right? Hopefully more and more people will, because it takes a licensed practitioner of the healing arts under scope of state law to get this ball rolling. So the strategy is, in Idaho, if that's one of the ones on the list. No, it's not. Yes, Iowa is, Illinois is. These are 2 of the 36 states where it doesn't matter what the family income is. If a licensed practitioner in those states prescribes a behavioral treatment program in exactly the same terms I would in Pennsylvania, those states are still part of the union, just like Pennsylvania is. So therefore, if it's legal in Pennsylvania and permissible and has been for 20 years, I've been doing it that long in Pennsylvania, then it has to be legal and permissible everywhere else in the country for kids who are enrolled in Medicaid. And the states on that list of 36, it doesn't matter what the kid's family income is. So this is the greatest treatment funding secret ever concealed. You have a licensed practitioner who courageously writes a treatment plan with all of the bells and whistles that I can show you in my sleep. And most of it's actually published on the website that I administer, and that is, for your benefit, www.ibc, Indigo Baker Charlie, hyphen like a minus sign, PA like Pennsylvania, .org, O-R-G. Go to that website, you can see a sample evaluation report, and you'll get everything that you really need. I've created treatmentplans.worked.com, where for the whopping fee of $65, you can download 576 treatment plans that worked with the data that shows they were successful. So I'm not in this for the money. I'm trying to get the word out and make a meager living for myself in the process. And that's what I do, and what I've had done for the last 20 years or so. So with the treatment plan written by a licensed practitioner in any given state, the parent takes that to the state Medicaid agency and says, I'd like to get this funded for my child because there are 17 examples that I have in my hand here of this type of plan that were written in Pennsylvania and funded under EPSDT for people with the same gender, at approximately the same age, and with the same disabilities that my child has. Please fund this. 25 hours a week of intensive individual treatment for a child with autism spectrum disorders. That's a one-to-one person going to the child's home or school or both for 25 hours a week. That is the minimum established by the National Academy of Sciences in 2001 for the treatment of children with symptoms of autism. Minimum. So it starts there and goes up. The American Academy of Pediatrics in 2007 and again in 2012 made the exact same recommendation, a minimum of 25 hours of intensive individualized treatment, like this, in the home, in the school. Now, in a typical kid's life, they might have 5 hours of OT, PT, and speech combined that they get in the school, maybe. So let's say we're not going to count that. So now a child needs a minimum of 20 hours of intensive individual treatment prescribed and funded under EPSDT as a civil right. What have we got here? We've got a solution to the kid's relentless failure to achieve developmental goals because they're getting treatment not like a sledgehammer driving the tack, but it's not a toothpick either. You can't treat children with desperate developmental needs with 3 hours of treatment a week. Stop. It's a waste of time. It proves that the insurance companies are right in withholding it, but it's driving a tack with a toothpick. They need a substantial amount of treatment. National Academy of Sciences, American Academy of Pediatrics, 25 hours minimum a week, year-round. Who can possibly fund that? The insurance companies were beaten to a pulp by autism advocates a few years ago, and now we have, I think, 30 states that have passed laws saying you have to fund autism treatment or else for kids in this state. And then there are a million little ways of loopholes to avoid that responsibility. The sad part is that every single state that implemented those laws had the support of the state Medicaid agency because that made it unnecessary and in fact impossible to bill Medicaid for those services. You have to first exhaust the private insurance. So you literally took a federal civil right, an entitlement, and the advocates, if you want to call them that, pushed forward this legislation that forces kids who were entitled as a civil right to Medicaid funding, forces them to go and beg on pleas to Blue Cross and Aetna and Magellan, these various private insurance companies, for their little piece, $36,000 a year. Well, for some kids' programs, kid getting 30 hours of treatment a week, costing $30, that's $900 a week. So how fast do you get from $900 to $36,000? That's 40 weeks. That's not even a year. So in 40 weeks, what happens when they hit the magic $36,000? Well, now it kicks into Medicaid. And all this is courtesy of the Autism Society of America and all the other advocacy groups that lined up and made the departments of mental health and mental retardation, departments of public welfare, all the state Medicaid agencies jump for joy that they were taking kids off Medicaid while still allowing the schools to tap it with reckless abandon. So the bottom line is, if you don't have a private insurance plan, you can tap Medicaid without restriction, and I'm going to show you the actual documents that prove that. You can tap Medicaid without restriction until the child doesn't need treatment anymore. EPSDT services must be provided to children enrolled in Medicaid whether or not the services are provided for in any other state plan. If they don't do it for adults, that doesn't matter. It's still got to be done for kids. And then finally, Medicaid, not the school, must pay for covered services to a child if funding is in dispute. Medicaid is actually the payer of first resort in schools. So every single school that says, no, we're not going to pay for this because it's supposed to be Medicaid funding it, they're absolutely correct according to IDEA and the state and federal Medicaid laws. What we're talking about are the two taps in the Medicaid keg. The school stream goes out the back. It's got a much bigger throat on it because it just goes without any kind of oversight. And then there is the Medicaid tap that goes out of the front that is usually a trickle that only the most well-connected families access. So they both run simultaneously. Let me get to that next slide that shows you. Understand that under Medicaid law, the Social Security Act, Medicaid, not the school system, must pay for covered services to a child. Covered services include one-to-one behavior support. And also, even when these services have been found necessary and included in a child's IEP or IFSP, Individual Family Service Plan. So we're talking birth to 21. Medicaid is the payer of first resort for services in a school because they are covered services when you talk about behavioral support. Medicaid law shall not restrict payment for covered services because such services are included in an IEP or IFSP. This is federal law. It's in 42 U.S. Code, Section 1396, Sections B and C. It only says covered services. So what are covered services? Covered services are services that are covered by EPSDT. You saw the list. Vision, dental, and other services, including mental health services. Now, under the Individuals with Disabilities Education Act, it says, if any public agency other than the educational agency is responsible for providing services under federal and state law, such public agency should fulfill that responsibility. So they both point at Medicaid as the payer of first resort. This is a memo that was sent by the Department of Public Welfare, which is the state Medicaid agency in Pennsylvania, to the Department of Education. The Department of Education contacted the Department of Public Welfare and said, hey, listen, these parents are refusing to sign their kid up for Medicaid because they think it's going to compromise or cut back on what the child could get through the other tap. So the State Department of Public Welfare puts it in writing, and this happened in December of 2009, in writing that the health-related services a student receives through the school-based access program, that's the back-end TAP, are separate and apart from the MA services a child receives outside of the school setting, the top TAP. And then they additionally amplified it by saying, additionally, there is no cap or limit on the total amount of money that may be paid by the MA program for school-based access program services or MA services that the MA-eligible child may receive. This is in all 50 states because it's, MA is medical assistance, Medicaid. Medical assistance is what Pennsylvania calls Medicaid. So you can see that this is truly the greatest treatment funding secret ever concealed. It is colossally helpful, but it's hopelessly underutilized.
And it's only for children who are eligible for Medicaid.
Right, the kid has to be enrolled in Medicaid. Here's a little quip. Any child who has an IEP is automatically eligible for Medicaid, as long as you're in one of the 36 states where a financial limit is not also required.
And Ohio is not one of those states.
That is correct. As far as I know, Ohio is not on the magic list. Now, this magic list comes from the Kaiser Family Foundation, which is an independent think tank that researches Medicaid all over the country. And this last list I published on my website comes from 2012. I haven't updated it. I'm going to do that tonight, tomorrow, whatever. But you go to the source. Don't ever take a secondary source's opinion as valid. Go to the Kaiser Family Foundation and look up Medicaid eligibility. And you'll see that there are 36 or more states. See, in between 2010 and 2012, Illinois was added to this list, but Rhode Island and Puerto Rico were taken off the list. So different legislatures can make different rules about Medicaid eligibility. The take-home message, though, is that once a child is enrolled in Medicaid, they are entitled, as a civil right, to treatment funding that is sufficient in amount, duration, and scope to reasonably achieve the purpose for which it was furnished. Now, if I furnish a service in accordance with these three criteria, this is the statement of medical necessity. It's in Pennsylvania law. That a service, you can read it, item, procedure, or level of care that is necessary for the proper treatment or management of an illness, injury, or disability is one that, and they give you three flavors. Any one of the three satisfies the criteria. The first is that it will, or is reasonably expected to, prevent the onset of an illness, condition, injury, or disability. So you can prescribe behavioral health rehabilitation services, BHRS, to prevent the onset of a disability, or to reduce or ameliorate the physical, mental, or developmental effects of an illness, condition, injury, or disability. Ameliorate means make better. Or you can prescribe it so that it will assist the recipient to achieve or maintain maximum functional capacity in performing daily activities, taking into account both the functional capacity of the recipient and those functional capacities that are appropriate for recipients of the same age. So the bottom line is, this is a hole big enough to drive a bus through. If you want to call it a loophole, call it a loophole. This is actually the federal standard implemented in Pennsylvania. Pennsylvania's law for medically necessary treatment is the closest companion to what the federal EPSDT standard states. Now, some states throw in a thing here that it has to be cost effective. Every single time since 1967, when the cost effectiveness card gets played, it's thrown out by federal courts. The EPSDT standard has never been retracted, reduced, eliminated in any way. Even when we went through that awful period a couple of years ago of sequestration, remember that? EPSDT wasn't touched because it's a civil right and they can't touch it. So when I do this talk, I talk about putting BHRS in a wraparound cup. I have about 10 minutes left, and I think rather than go into what I do, let me just summarize it this way. It's all explained in the purple brochure, so by all means take this with you. We have behavior specialist consultants. These are master's level mental health professionals who go to the child's home, go to the school, collect outcome data weekly using a criterion referenced measure that we created ourselves. You know what criterion referenced means, you know? You have a treatment program that's supposed to accomplish these goals. How are we doing, Mrs. Jones? We don't ask our own staff, how good are you doing? What are we going to get? Oh, I did great today. I did even better today. Of course, that's self-fulfilling. You can't do that. But if I ask a parent, hey, Mrs. Jones, how do you think we've done in the school? And they look at you and they say, how am I supposed to know? Ding! You're supposed to know because you're in charge of your own child's education program. So how are we going to bring you into that fold in an authority position? We're going to show you how. And now the parent is becoming a more active and involved member of the kid's education program. Everybody benefits. And the parent's telling us, well, listen, Bob was supposed to be here at 3 o'clock and he never showed last week. Really? So now we go look at Bob's billing and say, well, Bob, you said you were at the house here. You're fired. We have zero tolerance for Medicaid fraud. And we don't have people who stick around who are perpetrating it. We are somewhat unique in that regard in the Medicaid world, as I'm sure you know. Medicaid is a hopelessly exploited golden goose, for lack of a better word, because the states offload their responsibility to monitor it to insurance companies who take liberties in their monitoring of it and restrict and prevent access to care that they can't prevent. So they do their thing, and most people don't fight it. Well, I fight it in a big way, and I'm still here and I'm still doing it. Yeah, sure. Every single year they come around and do their inspection. They come loaded for bear and they leave with rabbit, because there's always there's always something, files get stuck on the bottom of a file drawer, whatever, it happens. But we don't tolerate criminal activity, and our staff are fired if they fall asleep on the job, right? Texting I will permit once, okay, because it's ubiquitous. They can't keep their hands off it, right? So we try to cope with the impairments of our staff as well as the bureaucratic structures, and that's why I'm still doing this in spite of my vigorous advocacy efforts, let's put it that way. All right, so we have master's level people, and they supervise up to 9 bachelor's level people. So we have people fresh out of college with a degree in psychology. Instead of bagging groceries or flipping burgers, they're actually working with kids who depend on them for a future. They're the force field repelling the pestilential influences they're surrounded by. I don't know how else to describe it. So they're around the kid, and gradually over time they get farther and farther away, and now the kid doesn't need help anymore. And just like your model in the kindergarten, 1st, 2nd, 3rd grade, this has a colossally productive influence on the kid's future. All of the things you're talking about, I am completely simpatico with, right? So you know it works from applications in schools. I know it works from applications with individual children. We're going to work good together, I hope, right? Okay. In addition to those 2 levels of care, we also have mobile therapists. These are also master's level mental health professionals. They're supervised a little less intensely because they're functionally autonomous professionals who are not yet licensed. Those are the characters who go into the schools. They give them a little janitor's closet, right? And they're seeing 5, maybe 9 kids a week for an hour, half an hour, whatever. And they're seeing the most troublesome kids, and they're going to the school classrooms that those kids occupy, consulting with the teachers, with the guidance counselor, the school psychologist, and the parents, and forming what I call a wraparound model. This is my little creation. What I do is effective treatment in a wraparound cup by adding BHRS to the wraparound model. Wraparound is a nice concept. It's, I think, an essential concept in the treatment service delivery. But if you don't put viable treatment in that cup, it's empty. You can wear it for a hat, for all the good it's going to do. You know, and Eric Bruns himself says effectively that in some of his federal court testimony, although most people who talk about wraparound literally talk about it as a substitute for treatment, which it is not. So when you put treatment inside a wraparound cup and use that philosophy, you have a model that will impact the lives of kids to the extent that no other treatment model will. When we start adding the evidence-based kernels to the BHRS model, oh my God! You know, it just keeps getting better and better. So these bachelor's level people stay in the field and they work and they finish their master's degree. Guess where they work when they get their MA? They now become mobile therapists or behavior specialists with my organization or others. And now they've worked for a few years and they can get licensed as a behavior specialist or maybe take the licensing exam and get their license to practice psychology. Then they become referral sources. So we've got this marvelous model for training, supervision, growth, and development to the point where the Pennsylvania Psychology Association actually gave us an award for our outstanding employee development program. So I really think that this is a model that should be replicated all over the country, all over the world. You know, as much as all of what you're doing is wonderfully applicable in schools, if you marry it to EPSDT funding and the BHRS model I've come up with, I think it's formidably more potent. The model I came up with is a force multiplier model for mental health treatment delivery. I'm one psychologist. I supervise 3 master's level mental health professionals, full-time equivalents, and each of them supervises 9. So I've got like almost 30 people that I am coordinating the work for. We have 5 psychologists in our group, and we are the largest psychology practice in the state of Pennsylvania, exclusively devoted to the treatment of children.
So do you see EPSDT being able to pay for PAX?
Absolutely, because all of your PAX, all of the evidence-based kernels are what? They're behavioral interventions, n'est-ce pas? So behavioral interventions are rehabilitative interventions. They're behavioral treatment interventions. So you write a treatment program that prescribes these various things, all the evidence-based kernels, and all of the other good stuff that you can add in from an educational as well as a behavioral treatment perspective. But you have to be careful. You're not doing education interventions. These are behavioral treatment programs for the remediation, amelioration of mental illness symptoms. So it has to be targeted to an individual. You can't do BHRS for a classroom. You know, and even attempts have been made to pervert the EPSDT mandate that says, well, we're going to have one person serving 3 kids. And okay, so now you're tied up with Eddie. What's Bob and Mary doing while you're tied up with Eddie? Well, we don't know. Oops. I mean, that is just crazy in its face. But yet, insurance companies keep trying to come up with ways to put the genie back in the bottle. What they should be doing is coming up with ways to see to it that the bottle is being managed properly. Take outcome data from the parents, not from the school, not from the providers, from the parents about how well the kid's doing. And do that every single week and hold the providers accountable for explaining, why didn't you do anything? It's been at a 10, 10, 10, 10 for weeks. This constitutes being a spectator as the ship's going down. You got your floating chair and you're going to sip your pina colada until it goes, stop, that's not remotely appropriate. So you take the data, you have the data influence the delivery of service. Wait a minute, what do we call that? That's applied behavior analysis. So now you have a time-honored, or at least revered, treatment modality. It's not necessarily so evidence-based because it's been diffused all over the globe. But the idea that data collection influences treatment delivery on an ongoing basis is the foundation for applied behavior analysis. You bring that into a child's life who's got a developmental disability or autism, and you have, without exception, the most likely treatment modality for that child. most likely to succeed. So when you do that for kids with ADHD symptoms, wait a minute, ADHD and autism overlap to the point where you can't diagnose ADHD if you're diagnosing autism. They are synonymous in some ways. So when the National Academy of Sciences says that a child with autism symptoms needs 25 hours of intensive individual treatment, that concept can be applied to kids with ADHD too. So it's not just kids on the autism spectrum, it's kids with symptoms of autism that are covered by the National Academy of Sciences and the American Academy of Pediatrics. So you take evidence-based kernels, you supplement these standard or traditional behavioral interventions, you write everything in behavioral terms, you take outcome data, and you package it in a treatment plan. Now it's a treatment plan being implemented by a bachelor's level one-to-one person under the supervision of a master's level supervisor with whom they meet once a week for training and supervision. And you're monitoring the outcome, and after 4 months you can present the data to the insurance company. We said we'd take it down by 2 points, and we did, but he's got 8 points to go before he's within the normal range, 2 or lower, and therefore we have proven that the treatment was appropriate because it's working, but it's not done yet. And now, because of the necessity to deliver treatment that is sufficient in amount, duration, and scope to reasonably achieve the purpose, our purpose is to maintain the child's functioning and to treat his existing condition and to prevent the worsening of his condition. That's why we're doing it, and that's why we still need 25 hours a week for the next 4 months too.
So if we have school-based clinicians that are visiting schools from outside mental health agencies, working with kids in the schools, if that child is in a PAX classroom, where can they go with that as far as, does it become billable hours on their Medicaid?
Yeah, it's billable hours even without the PAX classroom. If you have a master's level mental health professional who is rendering a prescribed treatment for the remediation or other purposes, you have to look up the definition of medically necessary treatment in your state. But if they're doing that, that's billable under Medicaid. If they're an outside agency that is enrolled in Medicaid, they can bill directly and have no liability to the school, no obligation at all for the school to fund it. Don't forget, IDEA says the school must provide services. That does not mean that the school has to pay for them. If the school says, yeah, we'll sign off, we'll agree that this outside outfit, like mine, can come in and deliver mental health and behavior support to the kid, that's all they have to do. They just have to agree to work with us.
Were you talking about billing for PAX?
Yeah.
Okay, so now billing for PAX. If you package the PAX as evidence-based kernels and as discrete behavioral interventions, you load them into the treatment plan. And now you are delivering a behavioral mental health treatment plan with these components to the child.
Yeah, I think she's asking about how you bill for that if you're providing it at school, not to an individual child in individual service.
I bill for services in the home, school, and or community, and so can that person.
I think where the differentiation is getting confused here is PAX is generally seen as a universal prevention strategy where
Right.
there's not a diagnosis.
Okay, but what we're talking about is two slightly different things. PAX as an overall prevention model can be implemented at a school-wide, classroom-wide, and even to some extent at an individual level. What I'm saying is you have a master's level mental health professional who is delivering it to an individual. As a mobile therapist, you are permitted to implement interventions for an identified patient, but you can include the siblings, the peer group, the teacher, other adults involved in the child's care within the context of your service delivery. As long as it's a face-to-face delivery system, it's billable under Medicaid.
So she couldn't teach the whole class, but she could talk to a teacher that was doing PAX.
And assist the teacher. She can introduce the PAX concepts, all of them, to the teacher. Assist the teacher in using them for her assigned child, always for her assigned child, and she can then monitor the classroom and its effect on the assigned child.
So
It's all focused to individuals.
Think about
Add to the data sheet or a separate data sheet that we have available. So here's the classroom behavior screens in one row, and down here is the next row down is the screen levels by the target child. And you will, and depending on whether it's an externalizing or an internalizing child, you can code those. And there's a direct relationship between what's happening in the classroom and the child's symptomatology. And so you're taking data. In fact, the intervention, the treatment intervention is changing the class for that target.
Right. And you can, there's nothing that says,
And it's a documentation.
it's a matter of how you use language. If you talk about it as an educational or classroom-wide intervention, leave that in your education documentation, because that's not what you're focusing on under Medicaid. You're focusing on an individual child who has specific needs with a behavioral treatment plan that is being integrated into the education system, the classroom as a whole.
Yeah, I'm just reading the medical necessity in the state of Ohio. So meets appropriate, generally accepted standards of medical practice. Yes, that would be true. Be appropriate to the illness or injury which is performed as to the type of service and expected outcome. Be appropriate to the intensity of service and the level of setting. That setting is important.
And setting appropriate for the level of service. That gets into, well, of course it's medically necessary, but not at the level you prescribed. Well, wait a minute, son. What are you saying? You know better than I do, who've seen the kid individually and then made all these interviews and wrote a report? You know better. Are you kidding? No court on earth since 1967 has ever found in that way. Ever.
Number 5, I think, is particularly useful in this instance. Be the lowest cost alternative that effectively addresses and treats the medical problem. So here we have something that the Washington State Institute for Public Policy says is the single most scientifically effective thing, and it is most effective for the highest risk kid.
All right, so the PAX system makes sense as the intervention, but what we're getting at is the cost of bringing it into the school district may be higher than they want to pay. But those cost limitations have always been struck down.
Now, here's point 8, or B, preventative health care, though customarily not thought of as a medical necessary service, is available through the department's early periodic screening, diagnosis, and treatment.
Have you now heard? That's precise.
Health check program through managed care plans that have contracted with the department. That's the other deal.
All right, so be aware that there's this magic little door that doesn't have a label on it. And behind that door is EPSDT funding. And nobody tells you that that's the door to knock on. Okay, nobody. One sec. And then behind the other door that's labeled treatment funding, there's a guy who hands out boxes of breath mints.
We have 4 or 5 children who've been formally diagnosed with ADHD in her classroom. And my school social worker has been trained by the national trainers and is also credentialed and licensed to write treatment plans. And would she be able to write that? And
If the prescriber is a licensed practitioner of the healing arts under scope of state law, they can prescribe the treatment that has to be funded under EPSDT. School psychologists can facilitate a kid's enrollment in Medicaid, but they're not necessarily a licensed practitioner of the healing arts, so they can't prescribe treatment. In some states, a licensed clinical social worker is a licensed practitioner of the healing arts, and they can prescribe it. You don't need to be a physician, a psychologist in that state. As far as I know for a fact, physicians can always prescribe mental health treatment, regardless of their expertise in that regard. Right? This is why pediatricians can prescribe Ritalin, because a kindergarten teacher recommends it.
We're from Nationwide Children's Hospital, so an outside mental health agency
who goes to Columbus City Schools free of charge to the school, has a caseload of like 20 kids, bills those individual kids Medicaid for individual and family therapy that we do. If we are doing PAX to the teacher, to the classroom of the kid, we can bill that kid's Medicaid for PAX?
If you are consulting to an adult or adults who are involved in that child's life, and you are smart enough to write it in behavioral terminology, an individual, you're doing it. But all you have to do is pick evidence-based kernels, make sure you use behavioral terminology in a prescription for a particular child, go in and treat the child and talk to all of the adults and peers. Oh my God, this is the answer, right? Funded entirely by Medicaid. Dennis, thank you for inviting me to this. More questions? You know, I'm going to be here until...
Break, and you can ask some questions
Yeah,
during the break.
yeah, I'll be here until Friday.